Friedmann. You should have just gotten a notification that we're recording. So thank you, Alexis. My name is Jessie Friedmann. I'm the Director of Public Policy for YouthCare. Thanks so much for joining us this afternoon. I'm losing my voice, but I am thrilled to introduce some of YouthCare's critical partners in the community. I'm going to hand it over to the experts here in just a minute, but just a few quick pieces of housekeeping. We are recording, as you should have just been notified. We are going to have a little bit of a presentation here from our partners, and then at the end, there'll be an opportunity for question and answer. So thanks to those who have already sent in questions. We have those. If you have other questions, we ask that you use the Q&A chat function, which should be at the bottom of the screen, and we'll go through those at the end of the presentation. So without further ado, introducing Abbie Woods and Johnny Ohta from Ryther and Dr. Taryn Hansen from Kaiser. And I will pass it over to you two. Thanks so much.
All right, boom. We'll start with Abbie Woods.
Thanks, Jessie. Yeah, so my name is Abbie. I am the outreach case manager for the MAT team. I work for Ryther, and then we obviously also work with YouthCare. So we've got our clinic and the YouthCare Orion Center. So a lot of my personal job is outreach, very intensive case management. I do a lot of driving around, tracking people down, making sure they get their medications, things like that. But really, I guess my job is just to facilitate, the growth of my clients. And that doesn't always include medication prescribing. Sometimes they don't get prescribed at all. But yeah, I think our jobs are kind of just to try to help the clients flourish and address their substance use along the way in some shape or form. And then I'll pass it over to Johnny, my coworker here, to introduce himself.
All right. Hi, my name is Johnny Ohta. I work for Ryther, and I work at the Orion Center. I work at the University District Youth Center, and I work also in a lot of different systems throughout King County. And over the last couple of years, I've been able to work with this team very intensely. And unfortunately, the reason why this team has come together is due to the fentanyl epidemic and crisis here in King County. And it's great that we have this great team, but the actual epidemic and what's going on with fentanyl in King County is not great at all. And I'd be happy if it went away and that we could focus on some other things that we do with young people. It's been a great gift to work closely with this team and with Dr. Hansen. And Dr. Hansen just rolls with us. She rolls around. We go deep. We go to some pretty whack places. We go to encampments. We go to houses where a lot of people don't even go. We hang out on the street talking to people. We meet people in different places. And we have a clinic at the Orion Center in which we sort of center ourselves as we go out into the community and do a lot of different work with people. And it's amazing when you have these resources and they're ready and available and mobile. And there's a lot of things that we can do and do with this team.
Hi. Well,
this is Dr. Taryn Hansen.
Hi. So I go by Dr. Taryn. I work for Kaiser Permanente. I'm a family doctor, but for the last, at least 2 years, I've just been focusing on working with youth struggling with substance use, and specifically in response to the fentanyl crisis. When we wrote this grant that created this team you see in front of us, we said, Ryther, YouthCare, and Kaiser Permanente were already working together. And so we wrote this grant to try and outreach youth who weren't coming in, we weren't seeing in the clinic, who weren't seeing with our traditional outreach. And we knew there was a substance use problem, but we actually predated the really big rise in the fentanyl crisis. So I feel lucky that we already had this established. And this team established, and we just continue to grow, and we learn from the young people we work with every day. So we're going to talk a lot today about, what the fentanyl crisis is currently, what we do. But I hope along the way, you just get this idea that we've been in the community, talking to people who are really in the thick of this and learning how to best serve them. So we hope to share some of those lessons too.
Okay, so what to expect today? We'll start off with talking about the fentanyl crisis and what we've learned from that crisis. Then get into who we are and what we do, as well as medications for opiate use disorder and other treatment options and why it matters. And then how to get started with our program. And then, yeah, questions at the end, like Jessie had mentioned.
So I'm gonna jump in. So King County put out a poster with the picture of these blue pills. I think it was about 3 years ago. We heard conversations about it. We were involved with young people that were using fentanyl in one way or another. But it was, for what we know now, that was obscure. It was bad, but it was not what we're dealing with now. And so we had this poster and we put it up on the walls, and little did we know what was going to come within the next 2 years. And as many people know, and actually, thankfully, many people don't know because they're not deeply immersed in this world. The fentanyl issue in King County is just gone so seriously. It's just really extremely bad. And even people who have used heroin and other drugs don't even use those drugs now. It's all about the blues. We call them the blues. And even when we meet people now, and just initial contact, you know, maybe the second or third question we ask them is, oh, are you on the blues? Like, it's like, we used to have a lot of other conversations with people, or you could do a drug and alcohol assessment or whatever. And now we ask them pretty quickly, like, are you on the blues? And that response, we get a yes to quite often, usually because we're interacting with them either on outreach, or they've been referred to us, or they're just calling us because they want help. The severity of this situation is so bad right now. The cost of these pills originally were like $25, $20, $15, 3 for $15. Then they were 10, then they were 5, and now people can go downtown and buy one of these pills that can kill you for $3 or less. And so the availability, the access and the availability and the cost have a great effect on this crisis that we're having in King County and all over the country. As many of us know, and some of us don't know, the powder form of fentanyl is coming in now, and that's causing a whole nother shift for us in what we're doing and what we're trying to pay attention to. And really, and one of the things that Dr. Hansen and I and Abbie get a lot, we get a lot of young people. I've worked with homeless young people for a long time, and then this happened, and now we get a lot of kids that are going to high school, they're partying, maybe getting a little bit of trouble, drinking, something like that, and within 2 or 3 months, they're in withdrawal from these pills, and they don't know what's happening to them. Mm-hmm. And that's when we get them in front of the doctor and try to do some stuff.
Mm-hmm. Dr. T, do you want to add anything to that?
Yeah, I think, so most people have heard of fentanyl. I guess the things I would just repeat so that we're all on the same page is fentanyl is a synthetically made opioid. It is powerful. So it's 50 times as powerful as heroin, 100 times as powerful as morphine. And some people are like, well, why this crisis? Why is it happening so quickly now? And why youth? Some of the reasons are in that it's just really readily available. We'll talk a little bit about how, because it comes in a pill form, it doesn't seem as dangerous. And, teens in general and young people 25 and under, they're already at a stage of development where they don't perceive risk as everybody else does as their brain matures. So, and then it's really fast acting. So something's more addictive if it's strong and fast acting. So it's more addictive. They're getting to an opiate use disorder really quickly before they or their families or people that they're involved with even know what to do. And then it can be harder to come off it because it's just, they're typically using it all day just not to get sick. So then there's this period of trying to get off of it and even try something else like the medications we talk about. That's trickier than it was with heroin or oxycodone or the other things we've heard about in other crises.
So that last slide, which you guys saw, and if you go downtown Seattle right now, you will see people smoking foil, and this is what they're doing. They're smoking fentanyl pills on foil. many people in many different environments are finding, their young people, their kids, their teenagers, and this foil, and they don't know what it is, and this is how it's used right now. And so this is part of really just paying attention to how this drug is used and trying to understand it the best we can. This is one of our clients actually downtown with the KOW reporter, and she was like, well, don't you want a picture? So we
one of the questions that we got from the participants was about like where people are getting the pills, and so I figured now is probably a good time. I think like honestly, like a lot of them get it from their friends. A lot of them, it's really very easy to walk downtown or in the international district, and I mean, I'll walk through a group of people standing around and get asked if I want blues. So it's very accessible, unfortunately. And if people are seeking it, they really won't have a hard time finding it, sadly.
And then, the other thing that goes with that is that because it is synthetic and it can be made in a lab, it's really easy to import and it's hard to detect because it's very powerful. A very, very small amount is all that's needed for each of these pills. So it's also easy to get in this country. It can be sent from China to Mexico in its not finished form, then finished down there and get into this country really easily. And we just know because we see people with like bags of them coming through. So we know it's everywhere, and that just like stopping it from coming in is a lot harder than with a naturally made drug.
So, we can talk about these things a lot, and we can do this work. We can cruise along and do this work for a while without having somebody close to us die. And when someone close to us dies, it's a game changer. It doesn't really matter, where you are, how close you are to this epidemic. When someone dies, it just has a tremendous effect on us, on our community, obviously their families. And as in this slide, as you can see, I was having conversations with a lot of people 10, 15 years ago about these kinds of graphs, and none of them spike like this. And the thing about what we work with young people, and so this is really, a lot of it is focused on, our work is focused on young people, and there's a very large number of people that are under 30 and in our age range category who die from overdoses and have died from overdose in King County. Is very close to us, and a lot of us have come into this work with different ideas about the work. And I realized a long time ago that this guy, Caleb Bantagreen, was all about death prevention. And I was kind of like, oh no, I'm about, I want to be about life enhancement. And now here we are, really kind of first and foremost doing death prevention, unfortunately. And then we do get the opportunity actually to take some of these young people and do a lot of other things with them. But you got to be alive to do that.
Mm-hmm.
And one thing, so, I mean, we're going to move on to what we do, just because I think that's where we have some ideas to offer and learning points, but this also doesn't capture the fact that it's disproportionately affecting young people. So the rate of drug overdose by age is greatly increased if you're under 30 compared to this rate. So overall, more people are dying from fentanyl, but the rate of young people dying is really disproportionate. And that's already the group that is least served by a lot of the work we're doing. It's just hard to access a lot of the systems. And we work with 14 to 25-year-olds, especially if you're under 18. There is a really big lack of accessible services that they know how to navigate.
Mm-hmm. All right. So what we've learned from young people. So like Dr. Taryn had hinted to earlier, I think especially initially, like the pills were not perceived to be as bad as like using needles or using heroin. So I think also like a lot of young people have told me that like they think that they're using Percocet. They think that they're actually using the drug that this is mimicked to be. at least initially. There are definitely a lot of people who use fentanyl. They know it's fentanyl. But yeah, I think that was a big eye opener for me to see like, oh, they don't actually know this. Like a lot of these young people are just jumping right on it because it seems harmless. Another thing that we have like seen as a pattern is that the first use is usually recreational. So it usually is with friends and not really seen as like a big deal. Initially, it's just become kind of more socialized. And so, you know, what we would see is like, oh my God, this young person is doing fentanyl. They're kind of just like, oh, I'm just trying another drug. I'm just experimenting, which leads into the rapid onset opioid use disorder. And I'll let Dr. T or Johnny speak to that.
Well, I'll speak to the second one, and then Dr. T will talk about the rapid onset, because it's a really big deal, and the fentanyl situation has just brought this to the forefront. Everybody, all the people that we work with, everybody who suffers from addiction, and people who are deep in addiction, nobody planned on that. No one thought, I can't wait to get addicted to fentanyl or heroin or crack or methamphetamine or anything. It's all recreational. It always starts as recreational. And that's something that we always want to remember as we focus on young people who are not in the recreational phase anymore. And actually, we do meet some young people now that think they are still, and they are not. The party is over. They just haven't realized it, and the consequences start to stack up. Mm-hmm. So the whole thing about the pill and how it seems not as bad, and most of us understand, you know, the imagery of all of these other drugs that we've decided are really bad, and then someone's like, oh, by the way, yeah, let's take a hit off that. You could snort that. You could just drop that, and it doesn't sound as bad and happens quickly. And Dr. T can talk a little bit more about rapid onset opiate use disorder.
Yeah, so I mean, I think I just want to call out that it's hard to talk about serious addiction in young people. And I think that people haven't wanted to have those conversations because it seems like it's an adult, you know, chronic disease for adults. And, you know, we're here talking about young people, some are younger than 14. Some people are trying it at 12 or 13, and they are not too young to have a substance use disorder. It's actually a lot of the patterns can start in adolescence. So I think we should start talking about it and naming it for what it is. So this rapid onset is an important concept because while they're busy experimenting or self-medicating or just like trying to recreate with their friends, they end up with an opiate use disorder. And what used to take, I mean, honestly, so somebody who was just using illicit pills before that were not fentanyl, or I mean, usually young people were not using heroin. It would take a year or more often is what, you know, so people were continuing to use and escalating their use, and a lot of other things were happening over that year. Whereas now people might be 2 months into it and they have something that they cannot stop. And a lot of other things have happened in their life that then also snowball and lead to their continuing use. So I think this like idea that in 2 months you can have an opiate use disorder that they don't understand, that the people around them don't understand, and really need to talk to somebody else and get help. That's something that's been very different in this crisis, and I think is also just accelerating the impact on youth.
I think one thing, having worked with homeless youth for a long time, and they do not have families for the most part, and so we're really working and focusing on that youth, with that youth, and focusing on them. And what happened in this last couple of years is we started getting a lot of people, young people who had families, who actually were calling us from a crisis situation in withdrawal, having first used a fentanyl pill within 3 or 6 months of that moment. And this whole thing unfolded because basically we don't say no to anybody at all. We just don't. We did build a clinic at the Orion Center for Homeless Youth, but we do not say no. And so now we're engaged with a lot of people who really were not looking like they were on any kind of trajectory towards opiate use disorder. And it happens so quickly. And when a young person is in withdrawal from fentanyl use, and they really think the world is going to end. And that's when we do have an opportunity to engage with them and their families. And the game has changed a little bit because working with families takes a lot of time and a lot of energy. And we do that also.
All right.
I want to say one more thing because I think it said the risk of death there. So the risk of death, I think a lot of it's talked about how powerful this is and the fact that each pill is not regulated. So you might have one pill with a dose that's extremely different than the other one. And there's really two groups of people. We work with a lot of people who've been using fentanyl for a long time. By the time we see it, long time, I guess now has changed because now we decide that, like, you know, even a couple months. But some people, if it is your very first pill, and that's what we talk about, and we'll have a little more to say about it later, one pill is what is most dangerous if people don't know that it's fentanyl. So this idea that there's one pill can kill, there's a statewide campaign, it's in many states, I'm sure there's a nationwide campaign. We're talking later about conversations with family, conversations with teens. It's something that people need to know, that it's not this idea that pill taking is risk-free or relatively risk-free needs to change, because this has changed the game. And then for the people who are using it all the time, we also see them overdosing, and we hear from them, sadly, like, oh, it's not going to be me. I use all the time. It's never happened. And it's those same people, you know, like Johnny was saying, nobody's trying to overdose, and the people that were, it's accidental overdoses with sometimes long-time users. And they have to smoke multiple times a day. So there's just increased numbers of times you're exposing yourself to the risk of overdose. You're also potentially more isolated, because if you're using with somebody, now you have to use with somebody many times a day to have somebody check on you. So I think it's just the risk of death is very real for somebody who's a first-time user, but it's also very real for the people who are continuing to use.
Yeah, and on that note, like, and we're about to talk about what we do, but like, because that risk is so high, like we found that like our speed and our ability to be flexible and have like a very quick response to these needs is like been really important for us to be able to make moves, because like you may or may not know, like usually you have this window, right, where the substance using person like decides they want to make a change, and if you don't respond in that window, sometimes they'll obviously change their mind. So we try to get in that window. So yeah, so about us, what we do, Johnny and I are case managers. We do very intensive case management. And it's really hard to describe what that means to people, but I become people's person, you know, like I become their go-to person to help them solve problems, help them achieve goals and all of that stuff. So I think like it's really important to like highlight that, like, yeah, prescribing is not the only thing that we do, and we actually do more of the other stuff probably than the actual prescribing. And Dr. T is definitely a part of that. We really like to like get to know our clients, you know, find out like what they're doing in their lives and like how we can help them get to where they want to go. And as we mentioned, like this team came out of a fentanyl crisis response. Our motto, Johnny likes to say, is we meet clients where they're at, but we don't leave them where they're at. So we all have the ability to outreach people in their homes and drop-in centers, shelters, wherever they want to meet us. I do a lot of work in encampments and stuff. So like we literally will meet them wherever. And then, you know, our goal is to help them move on to like wherever they're wanting to go. And then even after they go wherever they're wanting to go, we still follow up with them and we're still a part of their lives. Another thing is obviously we have the medical clinic at the Orion Center, and we have that on Mondays and Fridays, and then we have a clinic at South Seattle, and that's on Tuesdays and Thursdays. And those clinics are, you know, can be primary care as well. We don't only do Suboxone prescribing, so people can get seen for any reason at our clinics. Our MAT team is mostly based in the Orion Center, though. That's generally where we have clients meet with us at some point. And then what we do is, you know, so we do medications for opiate use disorder, and we'll get into those specifics on the next slide. Harm reduction. So I provide a lot of harm reduction supplies, and we kind of just have like this harm reduction style of approaching people, you know, which goes back to the meeting them where they're at. And then, you know, that case management outreach, we have a mental health therapist on our team, and Johnny and I are licensed substance use disorder professionals. So we also do a little bit of counseling here and there. And then just a little. And then we also can provide referrals to other treatment options, housing navigations, anything that we're not able to meet ourselves, we are able to make referrals for, and sometimes that's where YouthCare comes in, or other agencies and partners that we work with. So we like to think that we're kind of a one-stop shop for folks, and hopefully we can point them in the right direction if we're not able to help them ourselves.
We do a lot of counseling, waiting in courtrooms with our clients and driving them to different places and take them to the clinic or the hospital or even to a park to just eat, or, you know, have coffee and talk. Like we really just try to do a lot of different things and be very creative. Well, I mean, we got one of our clients, most of their teeth pulled out, and it took us, I think, more than a year to get them new teeth, and it was a team effort. And we also have a huge support from private funding that supports client assistance, so that when we go and say, yes, we can help you get your teeth, that we know that we'll be able to follow through with that. We support people going to inpatient treatment, outpatient treatment, getting on medication-assisted therapy, clean and sober housing, helping them engage with transportation. We're all about Orca cards and phones and connection. And so we actually have been supported both publicly but also privately to really do this kind of work that we try not to have any barriers in front of us. There's always barriers, but the kinds of things when Abbie, or I'll call Abbie and be like, hey, do you think we can do this? This girl's going to go to treatment tomorrow, but we need $1,200, you know, and like we can say yes to that. We can say yes to a lot of things, that there's not a lot of hierarchy to go through. And that is something I've never experienced in my life, in my work. And it's really great right now because we pay for prescriptions. A lot of people have different types of insurance, or even if it's taking too long and we just have to get the medication, we pay for the medication and we pick it up and we go meet the client wherever they are. And I had a client who just graduated from physical therapy assistant school, and she had a lot of self-harm scars on her arm, and she needed to do her clinicals, and she didn't want her arms to be shown to her patients. So we were able to get her tattoos all over her arms for that. And that's just the kind of stuff that we brainstorm about, but also are being supported in doing that. And it's not willy-nilly. We really do focus in on things that might help people get to a different place and overcome some of the barriers that a lot of other organizations and programs have. We still have some, but we're trying to knock them down.
I think I was just going to talk to you just briefly. So I used to provide these services in a Kaiser Permanente clinic on Capitol Hill. So people would come to me, and everybody would have to go through a lot of steps before they got to me. And really, until I started working in the community and working specifically with youth and young adults, you realize how many barriers there are and just the great resources we have. So, you know, even if sometimes we've gotten questions like, well, I'm a prescriber, why don't I see any of these people in my clinics? Why are people so underserved? And I think I just want to call attention to the idea that these are young people and young adults who have also been very stigmatized by a lot of the systems we work in. And so if you think about all the phone calls you have to make to get an appointment with somebody, you probably already know your insurance and who your doctor is. And now you have to call the front desk and explain why you need it and wait all these days and do the initial visits. All of that, I mean, and that's just the most basic level, is in the way, because a lot of times they're calling when they're in like a crisis or they're in that moment of change, and they're not going to wait 2 weeks to figure out all that. Or there's a lot of just frustration, their frustration tolerance of all young people. And then you add is low, and then you add the stigma of the systems we work in. So I feel really lucky because I get to go out and be with people where they're comfortable, and then we build that relationship, and then they come to a clinic. And Abbie's brought people in who are like, oh my gosh, I would never come to a doctor's clinic. And then they come and they meet me, and then they go to treatment and they say, oh yeah, I have a doctor, and they can say my name. And that's like a really cool thing as a family doctor who wants to build those relationships. I think for me, it's just like, I do try to meet them. I try to meet them the first day. We try to get a medication on our first day because that's like our point of contact. But I know in the back of my mind, it's all about like, okay, well, what are their other goals? What are they about? How do we get a relationship built? Because that's why we really get to do the longer work, which is the ones we find like, I think that's why we're all here. That's why we are still doing it.
Another example of like our model that was really cool that happened yesterday. I did some outreach. I just want to give this as an example because I feel like it's hard to talk, like it's hard to describe exactly how it works, but I feel like this was a great example. So I did some outreach and encampment. I had met the girl that day when it was the day before it was getting swept. Came back the next day when it was getting swept, helped her move into a tiny house village. Lost touch with her. And then a couple of weeks ago, I got a call from her attorney and said that she was in jail, which is a bummer. But for us, it's also an opportunity to see if they're ready to make some changes. And so, yeah, I was like, he's like, can you pick her up from jail? So I went to pick her up from jail yesterday. We called Dr. Taryn. Dr. Taryn got her a prescription. I went and picked it up for her. I brought it back to her. And then I watched her as she took it, and now she's on Suboxone, and she didn't use last night after she got out of jail, which is just like, it's just really cool. And like, you know, next steps, we'll take her to meet Dr. Taryn in person, and then we'll start working on, you know, her ID, getting a job, securing permanent housing, and those types of things. But yeah, I just thought that was a really good example of like how it works from referral to prescription.
That's a great example.
I know, it's like a perfect
And
example.
yeah, and Abbie met with her today, and this is how we you know, I a lot of people give me crap about this, but I see Suboxone specifically as an engagement tool that we get to engage people on a medication that may help them both in the moment and maybe later. But it is an opportunity for us to get them in front of the doctor and offer some of our other things that we're able to do for people. So it is a medication, and it has a lot of value in a lot of different ways. But for me, quite often, it has a lot of value in like really just saying, hey, or you want to get on Suboxone, let's go see the doctor.
Okay, so the MOED options, we'll let Dr. T take this one since she knows the most about them.
Yeah, and so I was just going to say, I know we have, you know, in about 10 minutes, we're going to have questions. So we're going to keep this as part of the slides so you can refer back. It's mainly so we can have a reference point so we all know what we're talking about. Suboxone is the most common one people hear talked about when we talk about medications for treatment of opioid use disorder. The active medication is buprenorphine. And it's important because that was a big change in treating opiate use disorder because it can be prescribed in primary care and low barrier clinics, and it's safe to have on the street, as opposed to methadone, where it's a very tightly regulated system and you have to show up and have supervised, take it in a supervised setting. So Suboxone is what we talk about a lot. Vivitrol and naltrexone is another one. So buprenorphine, naltrexone, and methadone are the three main classes of medication that are evidence-based for treating opiate use disorder. The one thing I'm just going to highlight on this page, because I think it's changed our practice a lot, is there is an injectable form of it's not really of Suboxone, it's just of the active ingredient of Suboxone, buprenorphine. It lasts a month, and I think we started using it about 2 years ago, and it has changed the trajectory of the recovery of a lot of our young people. And so I've made it a point of bringing it up whenever I'm talking to them, and not necessarily as their first medication, but so they know that there's another option out there. I think when people quote unquote fail oral Suboxone, they feel at a loss and don't know what to do. And so like just knowing all of these treatments are available, we offer all of them. People can come back and talk to me, and really having something that you use once a month and make a decision once a month for young people has been a game changer.
Thank you, Dr. T. So why it matters. I think for us, like obviously the number one thing is death prevention, and helping people stabilize. I feel like I came from this setting of like a traditional treatment model, like that's where I came from and I trained in. And then I came out here and like my whole world was flipped upside down because I was like, you're prescribing youth Suboxone? I don't understand.
What are you doing?
Yeah, I just didn't understand. And now like my whole perspective has really shifted because like, you know, it's hard to talk about, but I think it's important to talk about like when you see somebody overdosing in front of your face who you love and care about, and you're like in this like fight or flight thing of like, are they gonna live or die right now? And like you're there with the Narcan and they come back and all that stuff. It completely shifts everything. Like it's just very obvious and very clear to me now, like why we're doing this, like because we're trying to save people's lives. And like Suboxone is not the answer to the fentanyl crisis. It's definitely not the answer, but if we can get someone a Sublocade shot, for example, that will like prevent overdose for at least a month, you know, well, hopefully it'll at least give them more protection against an overdose for at least a month. And for us, like that's the reason why, like we're trying to keep them alive. Number one, we're trying to keep them alive. And then if we get to do all the other cool stuff, that's awesome. So that's just what I wanted to share about that and why it matters to me.
Yeah, no, thank you, Abbie. I mean, I don't know. A lot of us have had to go through a lot of different processes to really embrace the work that we do, and I continue to every day. It changes every day. I pay attention to the changes. I get to roll with Dr. T all the time and kind of pay attention to all the medications, how they can work, what they can do. But actually, in talking to other people, it's really important sometimes to just get right down to the fact that people are dying, and it may shift your view if you can see that, feel that, and understand that. We spend a lot of time with we really try to offer the whole show, really truly the whole show, that we can participate in you being in an encampment, smoking fentanyl, shooting meth and heroin in a big pile of trash, and we will be there and sit there with you and talk to you and bring you stuff and take you to appointments. And we also help people go to treatment and clean and sober housing and stabilize their lives differently and become employed and go to college and have babies and all those things. And we try to be present, completely present for all of these possibilities. And up front, like death prevention is the thing that matters right now. And when we engage with someone and we know they're smoking fentanyl, we know their risk of death is high, we try, we're just, we pay attention.
Yeah, and I would just say, interestingly enough, when you're talking to people about Suboxone or the other medications for opiate use disorder, most of them, the thing that doesn't resonate as much is that they are at risk of death, or that's not why they're trying to get on Suboxone. A lot of it is this short-term, day-to-day, can I get through today without being sick? Can I have my life back because I've lost myself along the way, where this is just all I do all day? And especially for young people who aren't expecting that. They're like, I do, what is my normal life? How do I get back to that? And so we care about death prevention. I know they care about it because they talk about it with their friends that they've lost. Johnny and I won't ever forget one of our first people who came in and who was a young person, under 18, saying that she was smoking fentanyl and handed a pill to a friend, and that pill was killed her friend in front of her. And just that powerful statement right there of what young people are having to go through and how that then fed into the worsening of her addiction and all the things she had to process to go through her recovery. We hear that story so many times, not necessarily that they gave that friend a pill, but maybe they were with them when they started smoking, or they've just lost friends. And these are young people we just shouldn't have to lose this many young victims. They have a lot of life in front of them, and young people are losing their friends, and we're losing them. So I think this is something we care to make sure that that message is getting out.
Mhm.
So how to get started with our program. Our intake and referral process are low barrier. That is so we can have a fast response. There's no like online form to fill out or anything. All you have to do is call us. Calling us is probably the quickest and easiest way. You can also email us, Johnny or I. And then we also have the clinic at the Orion Center. So folks can also access us through the Orion Center. And also our doctors that are there that are not Dr. Taryn can also do Suboxone prescribing if needed and stuff like that. So yeah, and then our phone numbers are I guess, yeah, I mean, no, you don't care. Our phone numbers are free to give to clients. So if you have clients that are interested in our program, feel free to give out our contact information. We don't mind.
Yes.
So yeah, that is that. And then I guess I did have a list of questions, but why don't we open it up for Q&A, I think. Oh, sorry. And then here's resources. So we just wanted to put a list of resources for folks to take a look at. And then this bottom one, the podcast, is great for parents and friends of opiate using folks. And I know there was a question in the list of questions that we received about how to best love somebody in addiction. And this podcast is a great resource for that. Through KUOW, they talk about advice for parents and friends. And with that, I think we can go to the questions. Should I stop?
Yeah.
Share?
I mean, I'll just jump in real quickly on, like, since Taryn and I have been doing all this together, and then we got Abbie on board, and we've been working in the juvenile justice system quite a bit and have really built great relationships there. Really, we're trying to, work closely with Children's Hospital, other ERs, DCYF. And we are spread kind of thin as we go and really try to say, hey, we're here and we're available, and maybe just also build on top of what we're doing now for other areas and other organizations that can do the same thing. So we do spend a lot of time on that. And I think the juvenile justice system here in King County is one that has been very beneficial, having Dr. Taryn really walk them through that process, and myself and the juvenile justice counselor, the JPCs, who are the probation counselors, and judges, and a lot of people are on board with what we're doing. And so we're still trying to engage with people that are engaging with young people.
Mm-hmm.
Great, thank you guys. That was wonderful. I'm going to try and kind of group the questions together a little bit and see if we can get them all answered. One that we've gotten a few times is about harm reduction. So we have one that says, speaking of eliminating barriers, are the harm reduction resources that Abbie mentioned available to youth 24/7? Is Narcan available to youth 24/7? We had another one asking if harm reduction services are available at the Orion Center. So I guess broadly, where can youth access them? When are they available? How do they get them?
So yes, we have supplies at the Orion Center in our office. We've got Narcan. I don't know if we have needles currently, but we've got needle
We do,
bins.
yes. We've had needle exchange for a long time.
Mm-hmm. And yeah, just any other harm reduction stuff we generally will have. We don't carry meth pipes. That's just a thing that our team does not do. And so those are accessible, at drop-in. Staff should be able to help them out, and that's from like 8 a.m. to 6 p.m. or something like that, or no, 6 p.m.
Yeah, I think this question is so a lot of things that we do, it's a general question, and so there's some specifics on what harm reduction supplies mean that we would have to kind of pull out, but really the truth is we have all that stuff and we're happy to help. sometimes when you walk into a place, any place, the first person you ask may not know all the answers to these things. So, but we work with the Orion Center, New Horizons, all of YouthCare, every single homeless youth provider in King County. And so we're constantly trying to make sure that these things are available.
And then also, like, it should be noted that youth can generally probably access some of the other adult organizations if they're over 18. So, you know, like public health or just other needle exchanges and things like that. But a lot of my personal like handing out of supplies happens on outreach, or if I know a client is using needles, for example, I'll like ask them every once in a while if they need any more or things like that.
Great. A few questions, and I know you mentioned the podcast in the previous slide, but any kind of quick thoughts you have, both how to talk to teens about overdoses and what is the best way to love someone with an opioid addiction? And again, would flag the resources in the previous slide, but if you guys have any other thoughts.
I think the how to talk to teens about overdose, I try because a lot of times, you know, I'm trying to feel out who they are and where they are. Sometimes we have groups of people, so it's kind of a general message. Sometimes we have just an individual, or we have an individual at risk of overdose, and so then we're tailoring that message to that individual and really talking about the reality of overdose. Adolescents in general don't think they're going to die, and they think they can jump off 2-story buildings and everything's going to be fine. And so really working with that knowledge and trying to take into account the person in front of you, especially if it's just 1 or 2 people, and then really just getting real about it every now and then and just saying, like, this is the real deal. People die, your friend died, they died. You know, can you embrace that? Can you feel that?
Mm-hmm.
And I tend to not say, do you want this to happen to you? Try to stay off of that a little bit, because there's plenty of other people in the world that are going to deliver that message. So we're really just trying to stay engaged with them and really talk about the reality of death.
Mm-hmm. I think like something that people often like misperceive is like that you have to like sugarcoat things for youth. I feel like most of the youth, especially if they're using like fentanyl, like they're not like a normal like 13, 14-year-old, you know, they're probably more with it, you know, people, they've probably been out on the streets, and you know, so it's really, I think talking to them like they were an adult, and you know, just talking to them like a regular person and not trying to sugarcoat it or dance around it.
Yeah, this shit's real, you know, like this shit's real.
Mm-hmm.
Yeah, and that's why we're here. We want to normalize that conversation that this is what's happening. It already is happening. We were talking about it happening 2 years ago to a lot of groups, and they're like, oh, really? Is it really happening to young people? And, you know, 2 years later, they're calling us up because it is already here. It's already affecting young people. And so they do need that knowledge that, you know, you can always tailor it to whatever age is appropriate. But if you're not saying that any pill could be dangerous, if you're not saying people have already died, if you're not saying, you know how to talk to somebody or have somebody you could talk to if you have questions. And then the rest of it is just normal prevention, you know, building strong relationships, open and positive communication with family or with other trusted adults, and all of the support systems and that we need in our community that we're trying to support. Like, it's not really just about addressing drug use, it's about addressing all of the support systems that lead to a lot of this in our communities. So bring knowledge, be real about it, and let them ask questions without judgment.
Great. A few other that I will group together. What are the best practices for breaking free of fentanyl? And what is your advice for someone that's resistant to medication-assisted care to break their addiction?
We talked about this earlier. So best practices for breaking free of fentanyl. I mean, it's like any other drug, and it's also a little bit different because of the intensity and the rapid onset. and the things that happen currently, the cost, all these things that have made these things kind of exacerbated. I think the biggest thing for us to do is try to really help people get a day or 2 or 3 without putting the drug in their body. These are people who are addicted to fentanyl, addicted to the blue pills for the most part, and utilizing lots of different things. We have parents that drive their kids to cabins. These kids get on Suboxone. We do like Suboxone induction in the Orion Center. We do all of these different things. We meet them in shelters. There's so many different things that we've tried to be creative about to help them get a day or 2 of not using fentanyl, or 3 or 4 or 5, utilizing the doctor, utilizing medication, and then really starting to talk to them a little bit more. Almost all of our young people don't want it. Well, yeah, we got a couple of very committed people who still want to use, but 95% of the people that we work with do not want to be addicted to fentanyl and smoke it all day, every day. So we're using that as a motivating tool. We help people get into detox. We'll go down any path with them to get a couple days or weeks strung together without using that particular drug, and then sort of as they put together a little bit of time, or relapse or struggle or come back or do these things that happen in addiction, we're always there to try to help them put together a little bit of time. And Dr. Taryn is going to answer the second part of the question.
Well, I mean, I think you can remind me the specifics, but I'll talk a little bit. Everybody kind of wants to know, well, is there evidence like, oh, this medication is better than the other one, or everybody has to be on a medication? And I think at all of the people, if we talked about the journey that we're on, especially with working with young people, it is not that everybody comes to us, we prescribe this one medication, they take it in this certain way, and then a certain number of months they come off of it and they march on their way. Like, it is a much more winding path. And so I think there is equal evidence that any of these medications that we just talked about can work for somebody. It's also true that we've seen it work. People have been able to do it without these medications, but by and large, almost every one of our people have used one of these medications that we talked about. So methadone, naltrexone, or buprenorphine at some point in their recovery. And then it really is just engaging with them to see which part they are most attached to and where they need help. Because if they don't have buy-in, I think the parts that we don't see work as well is when they're like forced to take a medication every day. You know, that's different than being in like a structured setting like jail or juvenile justice. Those structured settings, people are usually asking and wanting to take those medications, and they're given them in a structured way, and they find benefit, and they've really latched onto them, as opposed to when they're totally not ready. And in another presentation, we could come back and just talk about these stages of change, but this goes into also how do you support somebody in your family. They have to be at a stage of change where they're wanting to take that. So we just offer all the options to it, and then we move really quickly when they even have an inkling that they're ready in that stage of change. And we just have to be super nimble because they're young people, and they're going to start it, stop it, try again, try something different, hear from a friend. And, you know, I can offer all the evidence in the world and it might not change their mind, but I'll still tell them. But, you know, I think you just have to be really nimble and ready to engage with them in wherever they're coming to you, which is very different than adults. So I think I want to just stress, we have to be nimble and know different ways to approach it because we are working with young people.
Which I think kind of segues into our next question, which is what services do you recommend for someone older than your clients? And we had another question earlier, kind of what the ages that are served by this program. I believe you said it was 14 to 25, but I don't know if there's any kind of flexibility for younger or older folks there.
We got a call from somebody a few months ago. And so I started talking to him and talked to the mom. And these 2 kids are like kicking heroin and kicking fentanyl. And I was like, okay, and get the doctor, and doctor prescribes them and everything. And then I'm like, later on, I'm like, so wait a minute, how old are they? So, well, 33 and 28. I was like, damn, they're a little out of our age range. So there's lots of all the things that we just talked about are available for adults. You know, as you enter into these systems where you have to, we have a client that has an appointment who's 26 now, and it's a month and a half out. to go to his appointment for Suboxone. And ours, if you call us right now, it'll be a couple hours out before we're figuring out how to get you prescribed. So that's really the difference with us right now with this team and our age range, but there are many services in King County to help people with all these medications. It's just that people need someone to help navigate it quite often. If they could do it on their own, it'd be great, but when you're stuck in addiction, it's really hard.
Some other like adult resources would be like the Hepatitis Education Project. They do harm reduction and Suboxone. They have their own Suboxone clinic as well. There's THS, Evergreen Treatment Services, lots of different resources, and also obviously always depends on insurance, which we don't have to worry about, which is great, but other places might. HEP Project doesn't, though, I don't think so. If there's any specific questions about resources that people might need, feel free to shoot us an email and I can send a list.
Yeah, and I think also when you're looking at places, so there's the 1-800 recovery helpline too, and you can look through it. It is overwhelming, but it's also trying to figure out what level of resources people need. So we do intensive case management along with all of, we do really broad services. Not everybody needs that. And the same is true of adults. So when I was working in a clinic, there was a lot of people who could come and make their appointments and didn't need all this intensive other kind of support. And so when you're trying to help somebody figuring out what level of support can they just go, you can go to primary care and get this at a lot of clinics, or do you need someplace that also has case management? Do you need it that also does a lot of other social needs that they're working on? So I think it's also on you to kind of figure out what level of support they need. And then there's lots of low barrier walk-in clinics. I mean, King County is lucky that we have providers. It just depends on what the wraparound services are that you need.
Great. And last question we have with 1 minute to spare. And also for those who've asked, we will be sending out the recording slides and some kind of supplemental material. So keep an eye out for that. What is your experience / response with opioid use combined with methamphetamine use in youth?
Oh, that's all Abbie's people. Just kidding.
I feel like that's a long answer, but yes, it is very high. And actually we're seeing more overdoses with people on methamphetamine. I recently had a client get laced with fentanyl and his methamphetamine who doesn't normally use fentanyl. So it's very prevalent and they go hand in hand together, and they're definitely probably like the highest for, I believe they are the highest for the overdoses in King County. So they go hand in hand a lot of the times. And yeah, it's really just, sometimes we're working on just addressing the opiate use at first and then addressing the meth use later. Sometimes we try to address them both at once. But yeah, that's definitely a very common thing and scary and dangerous.
Yeah, it's very common. And we, as most people know, that we have a lot of things for opiate use disorder and not a lot of things to treat specifically methamphetamine use. And so to be honest with you, like one's easier than the other, because we're like, boom, like let's do this. We have methadone, we have Suboxone, we have all these things. We actually have a withdrawal cycle that has an end to it. So there's all these factors that we take into account. And but methamphetamine, really does cause a lot of problems with a lot of people. And we actually, given the opportunity, will zoom in on that and be like, this is not looking good. And most of our clients are, aware of that. And slowly but surely, many of them have stopped using one or both of those substances.
Yeah, I think it's a long conversation. You guys
Great. Well,
use different tools. And I think often when you address one of their substance use disorders, the other one improves. And so we're really just having a conversation with people about what's driving what and how to address the whole person.
Yeah, meth is messy and opiates kill you, and they both kill you. But it's when we meet our clients and we're like, okay, what are you using, blah, blah, blah. And then we shift. We're like, all right, meth all right, we're going to shift. I'm getting ready for this. We're going to prepare ourselves for some of the other things that come with those substances.
Great. And we are at time. So for those who have to drop off, thanks for being here. We just have one more question, and I think it's an important one to talk about. How much is a lethal dose of fentanyl?
It's a tiny amount, like, smaller than you're going to put on the end of your finger. So the reason it makes it really hard is because fentanyl is in these pills that are counterfeit, and you don't actually know how much is in any pill. So if you think about that as any pill could have a lethal dose easily, because it's much smaller than the amount that could be in a pill. And then that it is already being laced in other drug supplies, including cocaine and heroin and meth. So any amount, it's really, really small. And that's why it's so tricky and dangerous.
Yeah, I think that was a shift from the heroin epidemic. Like people would say like, oh, I'm only going to use this much. But with the pill, it's like, it doesn't matter how much. Like it could be fine for one person and the next person uses the same thing, could overdose. So really just, it just depends, unfortunately, which is also another scary part of it.
Mm-hmm.
Great. Well, thanks to everyone for joining. Thanks, Abbie and Johnny and Dr. Taryn for being here with us today. Thanks, Alexis, for managing the back end of everything. We'll be sending out the recording and the slides and some kind of other materials in the next couple of days, but feel free to email any other questions you have, and we'll do our best to get those answered. And I think that brings us to the end of our time today. So thanks again for being here. Abbie, Johnny, Dr. Taryn, any final words?
Yeah, final words are this. Well, I've already sworn once, so I'll swear again. This is really serious. And we're really trying our best to engage with as many people as possible.
Yeah, just how urgent it is, and that we're not at the peak of it yet.
Great. Well, on that note, thanks everyone, and we'll talk to y'all more soon. Appreciate you being here.